So today in the lab, what you'll see is a number of different techniques. Some of them will be new, but many of them will be techniques that you already know and applications to areas that are just specifically defined to certain disease conditions with the modifications in the pediatric patient. So hopefully this will help you, particularly when you get back here on campus. And we are, of course, hoping that will be in a couple of weeks when we'll all get to see each other and be able to practice on each other here. So some of this will make sense. We talked this morning a little bit about the Chapman's reflex locations. We did look at the large intestine and that triangle that was in the back, but remember you also have in constipation and diarrhea, you also have the small intestinal area with the viscerosomatics. You had mentioned that that was the T12 to L1 location as well, paravertebrally. On the anterior surface, you'll notice that the small intestine is located in the lower chondral block of the rib cage and between the ribs. And you'll also notice that the middle ear, again, another one of the concentrations today, are in the rib area just below the clavicle and the second rib. The colon, as we had mentioned before, is laid on the lateral side or the lateral anterior lateral side of the thigh. So if we take a look at otitis media, remember one of the things to do in order to apply a technique is to actually make a diagnosis of the area. If you're looking at the lymphatic system and considering that, for anything in the head and neck location, you would have to, of course, create and open up that area in the cervical thoracic region. So here, we are looking at a technique that you've seen before, but that opens up the thoracic inlet. The thoracic inlet, remember, anatomically also includes, and functionally, I should say, also includes T2 and rib 2, but anatomically includes rib 1. So you have the cervical thoracic junction and the first set of ribs along with the clavicle. And that's one of the reasons why you would then take your hands on the anterior posterior surfaces. And Tanya, can you please do the overhead camera, please? So you'd have your patient here lying here, and your hand position would be very similar to what you would have in the adult population, but obviously the size differential will allow you to have more contact with the clavicle and the first and second rib. The diagnosis would be you could then turn towards the patient's left side. So taking it and turning that wheel towards the left and checking for that particular ease of motion. Okay. Sorry, we just had a little bit of a composition. Here we go. Thank you very much. So your hands on the pediatric population, again, if this is a toddler or a preteen, you would be able to easily grasp over the clavicle going down to the first and second rib. That drive the bus component is a comparison and ease of fascial motion for rotation to one side, then rotation to another side. It is ease, remember we're comparing right to left, front to back, of a flexion component versus an extension component. And you will also see in some instances, a side bending. So this particular technique, to treat the thoracic inlet, this myofascial technique, remember you can use either a direct or indirect motion You can use the concept of stacking, meaning going from one plane to another position to another position. And you can use respiratory assist. And so those are the individual choices that you have as a provider in order to treat once you find the fascial binds and eases that you can do with this person. So if you were going to do a direct myofascial release and stack all of the restrictions, you could then hold it. So in this case, I'm going to just choose for demonstration purposes a bind on the left versus an ease to the right, bind to the left, bind in flexion versus extension, flexion versus extension. And then I'm going to add a slight side bending or pushing towards the patient's left versus pushing towards the patient's right. So I'm going to say, if this is a direct technique, I'm going to engage all three of those direct barriers. So let's say it's to the left, it is flexed, and it is side bent to, or translated, for whatever reason, to the patient's left. I'm going to hold that. That's a direct technique. You then have the option of adding respiratory assist, meaning you can have your patient inhale and exhale and find out which respiratory phase causes those tissues to bind even more. So a direct position with a direct respiratory assist and have them hold it. Obviously, with a young child, that respiratory assist may not be an option, but that is something to consider. So releasing the thoracic inlet with a myofascial technique is one possibility that helps open that drain to allow drainage for otitis media or upper respiratory infection. May we go back to the PowerPoint, please? Are there any questions there so far? It's working on children, yes. So what is the apprehension on working on children? That's a really good point to address. Is it that you feel like you're going to hurt them?
For me personally, I was just concerned more about not so much techniques or anatomy or anything like that, just that you could do something in them fascially or to like the coverings of their bones or something that's underdeveloped that then affects them for the rest of their lives. That scares me. Also, they're just tiny people and they trust you, and I don't like that. I like people to be a little bit wary, but kids just kind of go with the flow. I don't know, maybe it's just my own kid makes me feel that way, but
right, and I think that that's a really good point. I mean, as a provider, when you start touching somebody else's child, you have to ask permission from the caregiver, but you also have to ask permission from the child. Excuse me. So in that instance, there's two different interactions that are occurring here, and obviously they came to the office or the hospital setting or whatever, and they need help. Part of the question is, do they want it? And the other part of the question is, even if they don't want it, does their caregiver want you to have it? So there's a couple of layers there. You always want to be very careful with other people's significant others, whether they're children or husbands and wives or brothers and sisters or anybody, any of their relatives, mom and dad, grandparents. That type of human touch and interaction are the things that we try to teach you in osteopathic principles and practices, but also in TDP and TPP, those soft skills, those relational skills that will help you make those diagnoses, make that connection. So for a young child, your first visit may not include treatment at all. That visit may be just to create some sort of familiarity before moving on, potentially before even making a diagnosis. Right? Your diagnosis then could be based on history and physical, but no treatment, no osteopathic manipulative medicine treatment diagnosis. So your apprehension is appropriate. Kids are usually pretty good. They'll tell you when it hurts. You're watching facial expression, body language. You're watching the expression on the caregiver to see, because they are intently watching at the same time. So going slow, going gentle, making the connection and the relationship is going to be extremely important to create that area and that surface of trust. So I think that was a very good point to bring up. You're not going to break a child any more than you're going to break an adult or a geriatric patient, because it's your own intuition and your own sense of feel and interaction that's going to gauge what you do. You're not going to push harder on a child than you would on your classmate. Does that make sense? The challenge is going to be if the child doesn't sit still or doesn't want it and the adult wants it. That's going to be where part of the challenge is. And so that's why I said if it's a time when they come to the office, and it's usually for their first visit, they're a little bit smaller child, infant, they're a little sleepy, it's a feeding time, they're more likely to be they're less likely to be reactive. If it's a school-age child, as this mannequin is, then yes, it can be challenging, and the interaction in the pediatric patient is not just the diagnosis, and it is not just the osteopathic manipulative treatment. But when we're talking about for your treatments and for your diagnosis, developing your palpatory skills and your interpersonal skills and your observational skills, you'll know if you're pushing too hard. And if it truly is something that you do not want to do, that's a contraindication, right? The permission that you obtain from the patient and from their caregiver is an absolute. The permission that you have for a certain technique and to treat a patient also comes from you. So if in a young child, for instance, and this is just a total different part of the conversation, if in a young child, they've been treated by chiropractors and they're fine, so it would be fine if you went and potentially did some high velocity on them. They wouldn't be as scared. Now, I'm not saying go do that. You could choose a different technique. But part of it's going to be your own skill and comfort level. If you're not comfortable with high velocity in the adult or in the child, don't do it. That's one of the reasons why we're teaching you a whole bunch of different techniques to treat and to make that physiology and to make that connection with that person. Some people like high velocity, some people don't. Some people like myofascial release and soft tissue, and some people don't. That's the art. That's part of the art of caring for these patients. Does that help? I'm just turning to my right because that's where my screen is, and I'm following the conversation. Did that answer your question? Okay. Can we go back to the PowerPoint then, please? So here you'll notice, for instance, just getting to that same point, that first picture, you'll see there's like 3 white coats there when there's somebody standing on the side. So that child could be very intimidated by white coats, because we know white coat syndrome does exist. But they could also be intimidated by the fact that they've got 4 people just standing there looking at them. Or the child may not care. So those are some other things that you have to be aware of. A great question. Hopefully that sparks some conversation and things to think about when interacting with different patient populations. So first technique, opening the drain at the cervical thoracic junction. In the lab, it's done by, in this particular lab, we're talking about a myofascial release technique. The other technique here is decompression of the condylar part. And by that, we mean the occipital condyles because of the various areas. You've done this before. Dr. Lund showed you last week. You're contacting underneath the supranuchal line in the area of the upper cervicals. You go to the camera, right? So you're under the supranuchal line. You have inion, bump of knowledge. You go down towards the feet. You're in the soft tissue up in that supranuchal line in that ridge. And you're contacting as far as you can. Obviously, you're not going to contact the condyles. But you're affecting the soft tissue here and the bony area to help drag and decompress the condyles. So on the mannequin, and you all had this done before, it's one of the most common techniques. You make a little bit of anterior pressure just to make contact, weight of the head, and then you bring your wrists together. So it's not just a lateral movement, it's condylar decompression is a lateral and 45-degree movement. But in the younger child, you don't have to, it isn't as dramatic as it is in the adult. The degrees of motion that you need to make in the child relative to the adult is less. The pressure that you need to contact the tissues is less than the adult. 1, because of form factor, but 2, because of actual mass. Questions there? So up underneath and out apart. And then you just hold that. And you wait for a softening or a release. You can also take a look and see if there's any changes in respiration or relaxation, changes in the facial features. And you just hold and wait. Back to the PowerPoint, please. Thank you. Another technique, and this would be directly for and because of the temporal bone. And the temporal bone and its relation to the middle ear eustachian tube. And in this case, as you can see in the picture, the pinna of the ear, the cartilage around the external auditory meatus. To the camera, please. The above camera. Okay. So as you can see, can you zoom in here? Thank you. So as you can see, this temporal bone And it's a little bit harder to see on the camera, but you know it's at the side of the head. You know that in the vault hold, your fingers are in front of and behind. This external auditory meatus, and I can't turn him here, you have your cartilage and your pinna, your ear. So in order to affect the temporal bone, you're going to use a lever, a short lever of the ear cartilage in order to affect this particular motion and drainage. And one way to do that, and this would be with equal and opposite pressure and pull, is to very gently grab the pinna, and you can just pull laterally ever so slightly and wait for a balance that occurs in between. Remember, the temporal bone attaches to the occiput. And if you take a look at the anatomy, the temporal bone is beveled and the articulations are beveled in such a way that you can slightly add some traction to them and not affect internal and external rotation adversely. And that will change the pressure and the orientation down into the eustachian tube. So you can pull out, you can, and that's one of the safer techniques, is just to gently grab that and pull. And you can try it on yourself, but you're not going to pull directly laterally. You're going to pull back, right? You're going to follow the angle of the ear. You're going to pull backwards, not just laterally. You could affect flexion and extension. Remember, these are paired bones. The temporal bone as a paired bone will externally and internally rotate. It won't flex and extend. But you can affect sphenobasilar symphysis, flexion and extension, by changing the position of how you are pulling or tugging. And that's what the slide is referring to. You can emphasize a flexion or extension of the sphenobasilar synchondrosis. Again, I've found that a child, working on a child, it's better for me not to address the SBS in this manner. You can. It's all related. You can only pull the skull bones far enough apart before you can't do anything with them. And I think once we're in person, I know you hate hearing that, and I know I hate saying it, but you'll be able to feel just how much that pull and tug is, just how gentle that is, and how you need to have a balanced motion. So I've pulled back and out to create the temporal bones to do this. You can pull them slightly forward to create a little bit of that, right? This versus that. And that's the little minor motions that they're talking about in that particular slide. So using the pinna as an arm to affect the temporal bones, which will then affect the eustachian tube. Questions on that? Anybody? Yeah. Back to the PowerPoint. Thank you. Another technique that will address the ear is by use of the mandible as its attachment to the temporal bone. If you have mandibular dysfunction, remember you could have translation of secondary altalgia in the ear. If people grind their teeth, they sometimes come with ear pain. And so otitis media, even though it is usually infectious, viral, or bacterial, or even if there's a swimmer's ear, which is usually external, ear pain itself can be addressed by use and treatment of the mandible. So you evaluate the mandible by placing your first and second fingertips at the TMJ, right in front of the ear, right by the tragus. And you palpate for tenderness and asymmetry. You ask the patient to slowly open and close their jaw as far as possible, and you're observing and feeling symmetry as well as motion. Remember, when we're talking about those TART findings, and we're looking at ranges of motion, we're looking at actual absolute degrees, and we're looking at fluidity of motion. So when someone opens their jaw, opens their mouth, you're watching to see, does that jaw deviate to one side when they open? Is there tenderness or pain or popping or something on one of those TMJ joints? And then when they close their mouth, the same thing. What is the actual motion? And when they're opening, how many finger breaths can you fit? Do they have a hard time eating an apple? Right? Something like that. You can create a muscle energy technique based upon the temporalis and the pterygoids. Remember, the lateral and medial pterygoid actually attached to the wings, actually attached to the sphenoid, arch of the sphenoid. So you can use the medial and lateral pterygoids as well as the temporalis and buccinators in order to address temporal mandibular joint problems. It's muscle energy. Concepts of muscle energy are very much the same. You find an area that's restricted. So if a jaw deviates to one side, you would have the person slightly open their mouth. And again, doing this more likely with an older person in the pediatric population because of ability to follow the instructions, as well as being able to sit still long enough to comply with what they need to do. You would have them slightly open their jaw. If one side is tight, you're going to pull the jaw. Can you go above, please? So let's say the left side is tight, meaning when this particular little one opens their mouth, their jaw deviates to the right side, to his left side, this side. So what I'm going to do, this side is tight, I'm going to take the jaw and slightly pull it ever so slightly over towards the person's right. And then I'm going to have them just gently try to bring their jaw to the left. I'm going to hold that resistance and match their force for 3 to 5 seconds. Have them relax. Give it a second. And then try to increase a little bit of motion towards the right. Have them contract against an equal force. So creating an isometric contraction, trying to pull their jaw to the left. It's the same principles of muscle energy. After 3 times of this, go back to normal, and then have them open and close their mouth and see if there's been any change. Questions or comments on that one? I'm sorry? Yes. Oh, painful to ear pull. Sorry, going back to the other question. There's a question in chat whether or not if the ear pull is painful. Was that just clarification? Was that painful on touch or painful on pull?
That was John's question.
I'm sorry?
I think that was John's question. Let me see.
Yeah, that was my question. I was wondering if the ear pull will at all be irritating to the kids, because like I figure it's connecting. Like I know it's not going to be as painful as otitis externa, but it still seems connected to an inflamed area.
It could be, so yes, I think I hear your question. If it's an external otitis media, you're not putting your finger in the canal, so that particular irritation wouldn't be there. The type of irritation that I've encountered, and please, any of the clinicians add to this, the type of irritation that I've found and the amount of motion that you're applying, I have not found it to be painful to the patient. But please, any clinicians, we have we have decades of experience of patient care in the room and online.
Yeah, I can also contribute to that. I've done a lot with earaches and using
hear
the
you?
earful.
Can
Yeah,
they-
they can hear me. I've got a microphone on. And I also teach adults how to do it to themselves at home. And so it's something you can definitely try when you have an inflamed ear. The big thing is just that.
Dr. Lund, sorry to interrupt, but your voice is super duper quiet and like hushed.
Okay, let me see if the mic is in the wrong place. Let's try this. Okay. So the ear pull, you can do it for adults or children. The biggest thing is to really monitor how the tissue is responding under your fingers. And it's a great thing for you as an osteopathic student and then physician to actually do to yourself when you're having plugged ears or irritation in the area, because you'll start to really appreciate what is the tissue response and what does that feel like internally. And that will also help you. I noticed in the chat somebody had mentioned children pull their ears when they feel sick. That in fact is them trying to self-regulate and self-heal. They know it can feel better if they just tug, and then maybe it'll pop a little, open up that eustachian tube.
Okay, did we answer the questions regarding the ear pull? Any questions on the mandibular muscle energy? Here you'll notice that Dr. Nicholas actually pushes the jaw to one side versus I crossed over and pulled. I think that is just a matter of comfort and stylization. I will say that crossing over a patient's midline is sometimes a little bit, it gives them a little bit more anxiety than pushing from the side. So those are just some minor variations and things to think about. I cross over because I find that it's less, I have to push less, kind of like I am spreading I'm spreading the tension that I'm placing on the jaw out a little further so that it's not point tender when I'm pushing. And so that is why I tend to preface it and do it this way, unless the patient becomes anxious that I'm crossing their midline and they think I'm going to close down on their neck. Okay. So for someone with ear pain or otitis media, we've opened the drain. We've tried to address the temporal bone, both directly by the ear pull with a short lever, and its attachment by the mandible. Another technique would be any soft tissue technique that you could do. Now here, this is just one of the many soft tissue techniques in the cervical spine that you learned. This one was called cradling with traction. You typically flex slightly forward, hold the head, contact in the cervical spine, and then gently have some longitudinal traction with some anterior contact. So this way you're not just slipping on the skin. It's soft tissue, so it's going to be direct. There's going to be, in this case, longitudinal traction. It's going to be repetitive. And those are some of the components that determine soft tissue technique, or this particular soft tissue technique. Can anybody tell me some of the other soft tissue techniques that you learned in the cervical spine?
Suboccipital.
Suboccipital inhibition and suboccipital release, correct? Right? Inhibition is a soft tissue technique. What else? What about contralateral traction? Flexion with contralateral traction. Remember this? Or this? Unilateral, bilateral. Do you remember this? Where you're on one side? I'm going to stand up so I don't cross. You're on one side and you're lifting up paravertebrally, right? You remember that? Those are all soft tissue techniques that can be done. You do them on the adult, you could do them on the child. Okay. Thank you. Back to the Ms. Friedman, I greatly appreciate you following me here because I know I'm jumping back and forth. For someone who has diarrhea and constipation, and I talk about those two here. Remember, we mentioned it in the didactic that you have to make sure that they're hydrated. One, if they have diarrhea, you don't want them to be dehydrated, right? Because that can actually cause dehydration. But if they had diarrhea, then they were dehydrated, that caused electrolyte imbalance, and you have a huge circle. But why I put them in categories here is because you're going to use the anatomy and the neuroanatomy connections the same way. The body is going to make the distinction as to what it will do. So if you have a hypersympathetic reaction, you can calm the sympathetics by directly affecting those areas, or you can change the sympathetic parasympathetic balance by making sure that the parasympathetics are working. The best would be to address both. So if the parasympathetics in this case, you're thinking about vagus for the GI system, and you're thinking about the colon, and you can go to the camera above, please. And you're thinking about the vagus on the right side going to the small intestine, right colon, 2/3 transverse colon, the right vagus, versus the pelvic splanchnics coming up the left side. You can do an OA release, or if there is an OA somatic dysfunction and you find that, again, a compliant patient and able to follow direction, you can do a muscle energy technique to evaluate that and treat it. That would address the vagus. The parasympathetics, you can do a sacral rock. Again, I would be very cautious on doing that in the first visit or two without first explaining that to the patient as well as the caregiver. But in order to address the thoracic and lumbar parts of not only the musculature, but the neural intervention through the thorax and lumbar, you can use such techniques as listed there. I think if I go on this side, I can stay away so you can see in the camera. Right? So it's very similar to what you would have done before. Come find the spinous process, go just a little bit lateral. And in this case, you can do paraspinal inhibition in the thoracic and lumbar areas. While you're there, you can repeat it and move on either side and up and down the area of the spine. While you're there, it would make sense to also address some of the soft tissue in the paraspinal area. So you could make that a soft tissue technique, right? A rolling technique, in addition to just doing inhibition. So two different types of soft tissue technique to address that thoracolumbar area. And then do it on either side. It's usually very gentle. It's usually not seen as being very invasive, and it's well tolerated. What other techniques have you learned for soft tissue in the lumbar and thoracic locations while the person is lying on their back? Again, the idea is to stretch.
Would rib raising be considered one?
You could do rib raising. It's not considered soft tissue, but that would be appropriate because the way the ribs attach to the vertebral column and the location of the sympathetic chain close to the area of the rib cage, you could definitely do rib raising. It's not, again, not considered a soft tissue technique. It's a specific technique within itself, but that's great thinking and I love it. The soft tissue technique, do you remember we had mentioned that with children, you sometimes need to play a game? So, and I'm not sure this is going to do it. We'll come close. So a game for a child could be something like this. Do you remember this type of technique? Where your knees, hips and knees were flexed. You were reaching over to one side and you were pushing and pulling with the knees. You remember that? You could do something as simple as that. You could do something as simple as totally flexing the hips and rolling their pelvis side to side to help address some of those lumbars. Part of it with children is to be creative, to be gentle, and to make it fun while you're doing the things that you're doing. Next technique. Oh, so here you, right? So this is simple to what you were saying before. You could do rib raising, which is which is depicted in that third and fourth picture, the colored pictures. You can address the rib cage. Remember, you first have to make a diagnosis. For soft tissue, it's by palpation. For the rib cage, for rib raising, it could be by palpation as well. It could also be an examination of the global evaluation of the ribs. Remember, for the ribs, the upper ribs primarily change anterior-posterior diameter and occur mostly in a pump handle direction. The lower part of the ribs, not 11 and 12, but the lower portion of the rib cage is primarily a bucket handle change, so a change in the transverse diameter during inhalation, exhalation. And the middle ribs are a combination of that, going from pump handle to bucket handle. So when you're evaluating ribs on a child, just like you are on an adult, you want to make sure that you're checking your anterior posterior motion, that you're checking your lateral excursion, and you can check for individual rib restrictions and that first rib, whether or not that is elevated. So remember, rib 1 is a little different than the others 2 and 3 and 4. There's a change in anterior-posterior motion, AP motion, but because of its attachments and the fact that it's small and it's under the clavicle, it also has this motion of elevation up to the ear when on deep inhalation. So you inhale and exhale. So you can have an elevated rib by coming back down through the trapezius on either end and finding out when they breathe if it stays elevated. Comments and questions there? So diagnosis, rib diagnosis, and then treatment. The treatment that we're showing in the lab is primarily rib raising, but you could do any of the other techniques too. Rib raising is easy in the child. It doesn't require them to be directional in any part. And your distraction, your use of distraction is in part your conversation. Or maybe they have a toy that they're using or working with. Or if it's a really small infant, then maybe they're drinking or feeding or sucking on something. Some sort of distraction that helps. So in the infant, a thoracic diaphragm release is very similar in some ways to the adult. It's similar only because you make a diagnosis. It's similar only because of the area of the anatomy. It's different because of the size proportion, the amount of pressure, and the fact that you could, just like in the adult, do one side versus another. One side first, then another. You could, as it's shown here in that upper right-hand picture, do it seated. The principles are the same. The patient position has changed. And in this case, the patient population has changed, which will change a little bit of your pressure it will change a little bit of the way that you're focusing on how to use those techniques. But the technique principle is the same as in the adult. The abdominal ganglia release, remember the abdominal ganglia, the celiac, superior mesenteric and inferior mesenteric are above the umbilicus. And all you're doing there is you're finding for tightness. Okay. Right, so the umbilicus is right here. In this case, instead of using multiple fingers, you might want to use one hand. You want to make sure you're using the flats of your fingers and not the tips, and your nails are well manicured, so there's no pressure. But again, when they breathe in, you let their abdomen rise, and when they exhale, you follow it down. You're trying to apply equal pressure amongst all three, but you follow it down. When they take another deep breath, slightly inhibit their full excursion. When they exhale, see how much further you can go down with them without hurting. And repeat that a couple of times. And then when you're not able to go further, just hold that for another breath cycle. And then on their next inhalation, slowly and gently release. So part of the technique is working with their body to get down to the pressure, to allow and follow, watch their face and see what their grimaces are or not. Talk with them and distract. Bend their knees if they need to. But work with their body and their body's tissues to get down further. And if the body doesn't allow you to go there, don't go there. Remember, however, you might find that you palpate the pulsation of the aorta. So make sure you're off center, offline of that. But that aortic pulse can take your attention, and that's fine. What you want to feel, though, is the pressure on your fingers and that evenness that's there. So if you find you're on the aorta, come off to the side one way or another, just slightly. Wait a second or so and see if you get a little further. If you can, great, and if you can't, that's fine. Go as far as you can go. Questions there? I don't see any. We talked about the mesenteric lift and the attachment of the mesenteries to the posterior abdominal wall. I think here it's the exact same thing. You're using a gentle pressure, pulling the visceral contents medially for the most part, but following those posterior attachments. So this way, you'll notice that you start in the, here, the picture is here. You start in the left lower quadrant towards the sigmoid and descending colon, but because of the anatomical differences, you'll probably have, depending upon the size of the patient, you may have to do what's located there in the lower right picture versus, remember in the adult, we took two hands and tried to scoop into the iliac crest on that side. So because of patient size relative to you, you might have to make that modification and use one hand to scoop on that side. And when we're doing the mesenteric lift on kids, should we give parents a heads up? I can only see part of the question. Sure. It could. It could. You know, part of it too with children is sometimes if they are wearing diapers, it's going to be different than if they're not, right? But you can tell the patient that they're going to, if they're feeling like they have to go to the restroom, let you know, so this way you can stop the treatment, you can let them go. There's no reason for it to be embarrassing to them in order to do that. You're trying to help them. When they come back, then just start where you left off and continue up that left side, the small intestine, and then up. And then up through the right side. And then a lot of times this is combined with what you'll see a little further on here, which is the colonic sweep, which is a little bit of pressure that kind of helps gently push whatever's stuck in there down out. So just like we opened the drain first and then had things pushed through, with the colonic sweep, remember the idea is to get the blockage that's furthest down, most distal, away first before you push something else closer across to that area. And it's a gentle motion and a little bit of pressure. Not good. And then the last thing here was something that I threw in there, because remember we were talking about the parasympathetics and the fact that the iliopsoas and the iliacus and the colon and the cecum all lie in those innominate locations. You might want to address evaluation of the innominate. In a child, again, they may not be willing or coordinated enough to push and pull when you say so. So when you diagnose innominates, you can place your hands very similarly like you would for evaluation of the innominates, please, across the iliac crest. And we know that one of the major motions is rotation, posterior or anterior. We know that it is out flare or in flare. Overhead camera, please. Thank you. Thank you. So we know that there is posterior rotation and anterior rotation of one of the innominates. We know that there is out flare and in flare. So you can, again, if one of the ways to test TART findings is by range of motion and restriction, you can very gently come up across the ASIS, look up underneath it. Let me get this other one. Thank you, Dr. Conkey. Come up across the ASIS, look up underneath it, and gently push posterior. And compare this motion to this motion, right side to left side to right side. Find out which one goes further, which one feels more restricted. And then you can, as an indirect treatment, hold those locations. You can also test for an anterior rotation by coming on top of the ASIS and rotating down towards the feet. And doing the same thing, you can do an in flare or out flare. So you can take each of those motions individually, again comparing right to left or anterior to posterior, or you can stack it. So you can take each of those motions, anterior and posterior, in flare and out flare, and just hold it indirectly. And as they're sitting there talking or breathing, that should help enhance that myofascial treatment of the innominate to then affect the musculature attachments through here and some of the pelvic splanchnics without actually directly addressing the sacrum on a young child. So by addressing the innominates, a fairly safe space, you can affect some of the relationships down there in the pelvis.
I'm going to add something verbally just to respond to a chat question.
Mhm.
It's easier than typing it out. There's different literature on with the mesenteric lift if you should start at the small intestines, move to the ascending, then the transverse, then the descending and sigmoid, or start at sigmoid and work your way back up toward the small intestines. Usually you should go in one order or the other order rather than starting in the middle and moving all around, okay? And then with the colonic sweep, where we're actually stimulating the colon, you do want to start at the sigmoid colon, get that to evacuate, then move farther up. So you're starting sigmoid and working your way back toward the ascending, but each time continually sweeping back toward that descending and sigmoid. Does that help with that question?
And some of the reason, and it's a great question, and thank you for the answer. One of the reasons why you want to clear out the far side first, if you have a blockage, there's a couple of ways you can address that, right? Just think of a tube that's blocked, that's closed, that's constricted. You can pull things from beyond that and make sure that that is cleared out, so this way you can push through it. Or you can just try to push through it, right? So you would start on the right side, if it's colon, you would start on the right side of the transverse and you just try to push through it. It's a little bit, probably, at least in my conceptual framework, it would be a little bit gentler on this visceral tube if you make sure that everything's moving first before you try to push the plug. Does that make sense? You could, as I said, just go the other way. Just like with the mesenteric lift, you could just start small intestine, because digestively that's where it goes first, and then it goes to this cecum and small right colon up through the transverse colon, left colon. So you could do that. There's nothing wrong with it, but just in my mind, it makes sense to kind of clear where you're pushing the stuff first before you actually push it through. So it doesn't hurt to do either way, but the efficacy and the reasoning will make a difference in how you approach treatment. Just like when we're asking you in clinical skills to kind of put together all the what you know about labs, tell me what's your differential and how do you substantiate the fact that that's how you got it? This is the same reasoning for me with these two techniques. Just like it's the same reasoning for me, clear the drain first at the cervical thoracic junction before you do lymphatic techniques, either from the head or from below, just because that right thoracic duct and the left thoracic duct, the right thoracic drainage region and the left thoracic duct all drain up into this area. So what other regions might you assess and treat for someone with diarrhea or constipation? Is there anything we might have missed? Thinking anatomy, thinking physiology, thinking about cause and effect.
Did we do OA for this one?
I'm sorry, did someone hear what that person said?
Did we do OA for this already?
You can do OA for it, yes.
And then I would address sacrum as well.
I was going to say, wouldn't you want to do the thoracic spine because the sympathetics?
Yes. So you could do a muscle energy technique or a high velocity technique for the thoracic spine. You could do a myofascial release directly on the thoracic vertebra. Great ideas. Does this kind of sound like it makes sense to people? Wonderful. Any other comments or questions? Faculty? Anything?
One thing I would add, this is Dr. Walker, is thinking about the concept of the key lesion and really diagnosing your patient's individual and specific somatic dysfunctions. We've done a great job of listing many regions that could be contributing. And while we may find dysfunction in all of them and want to treat all of them, it may be for one patient with the same condition, it's one thing, another condition with the same, another patient with the same condition, it's something else that's more out of alignment, and then focusing the treatment there, and sometimes realizing that dysfunctions are connected to each other. And if you treat one, then other things start to resolve, and noticing when something is more abnormal than others, and really identifying variation in the somatic dysfunction pattern underlying the same condition, patient to patient.
So that's what, thank you. And I think that's one of the reasons why it's good to think through how and why you would address these different areas, because you may not have somatic dysfunction in all of them. Or you may not have the time to do all of them. So, you know, again, creating a rationale and a plan is one thing. Dr. Lund, are you going to say something?
All right, did the microphone, is it louder this time?
A little bit.
Okay, otherwise I have to put it under the mask. One of the things that's also great with pediatrics is, let's say Dr. Chen is the treating physician, you can always encourage parents to be in a seat right next to the child, or even sometimes sitting on, they'll hold a hand. If you are a visiting student, sometimes patients that have been treated often will allow you to sit and engage and talk and maybe actually monitor some tissue texture change or something like that. And it's just comes with time and practice to actually put our hand on a child. But engaging with them, a lot of the physicians that regularly treat pediatricians have another coworker that's there strictly to entertain the child in order to keep them laying down. That's why we have the picture. Yes, there's 4 white cuts in that one. But you'll notice there's also like a tablet game thing that one of them's holding, and it's keeping the child engaged and interested in what's going on the table. Other times, you have to modify your position. They may be sitting, sometimes they're actually walking around. And sometimes you do little activities with them just to get them, like Dr. Chen said, making it a game before you start. One of the great ways to stimulate our parasympathetics our sympathetics, our lumbar paraspinal muscles to really help with the GI is to simply do hip circles. With a child, they hang on, they're standing, holding a table. You can be there and you can be like, let's do hula hoops. Let's do hula hoops. And they think it's so fun. So you find ways to get them moving and engaged. That's all I have.
And that's a very good point. So again, it's going to vary from person to person, right? And from child to child. And it's going to depend upon how old the child is, how cooperative they are, how tired they are, if they're irritable because they just had a really bad day and they just happened to be in your office that day, it's going to be a very different visit than the child that says, okay, I'm ready for a treatment. I'm hopping up here. I'm just going to lay still. Go ahead, do it. And that happens too. If the parent or a caregiver needs to actually hold the child because the child's closer to the infant stage, learning how to treat that infant or that aged child in the caregiver's lap, either facing you on the side or on their, where you're working on their back, those are all important things because the caregiver can hold them and just not hold to restrain, but hold to comfort. So when we're talking about these particular techniques and these particular diagnostic areas and trying to tie them to the anatomy and the physiology to clinical scenarios, that's all very similar. How you apply the techniques and the art, that's different. That's different. And that's what makes it really very engaging. And it really makes it very different for you as the person doing the technique and interacting. Anything else, anybody? Some things to think about. Appreciate your attention. Take a look at some of these things and consider how you would take these techniques, many of which you've seen before, how you may apply them or modify them, but why you would use them. So if a parent asks you why you're pressing on their child's belly, how can you tell them in common language what you're doing and why? So that there's, again, a development of trust and relationship, but you're using common language, not the language that we're talking about that communicates between clinicians or healthcare providers, but the common language that makes you interact with and respond to and have your patients and your patients' families respond to you to make this a very acceptable treatment modality. Things to think about. Your clinicals are 6 months away, like it or not. You may or may not use these techniques, but what I want you to do is to think about using them, think about at least how and why you would use them, and if on clinicals your attending physician and the patient allows you to do it, at least feel the difference in diagnosis and then see what you can do. Do a safe technique. Do something that's going to be non-invasive. Do something that you feel more comfortable with. And just do a little step at a time. I think that's where you're going to start to get your confidence in using this in the patient populations that you will see. Whether it's in the hospital, the outpatient setting, the recovery room, on the field for sports injuries, whatever it is, just try a little something. The preclinical, yes. One thing at a time. But those types of things, those goals, those next steps are going to get you from one place to another. All right, everyone. I don't want to belabor the point. Thanks so much. And I look forward to seeing you all in person in a couple of weeks.
Thank you.
Thank you.
Thank
Thanks,
you.
Dr. Chen.
Take care.
Oh, Dr. Chen. Thank you.
Yes.
Does that mean, are we coming back next week?
Oh, so according to Dr. I can still kept myself on. According to Dr. Qureshi's email, we're thinking of having everybody back the week of February 7th. but we are monitoring the local situation here. So if
Okay.
you are, because we're remote, and I'm just saying this because I know it's out there,
Mhm.
if you're in Florida, come on back.
Okay.
If you're in San Fran, you come on back, but you don't have to, do it as soon. But yes, we're hoping that classes will be at least the labs will be in person that week of February 7th. Again, if there is a spike and the numbers don't look like they're going down or, hospitalizations are still saying high. Right now, the preliminary results here in Fresno show that there may be a decrease, but it's too early to know.
Thank you. I just wanted to check in with you on that.
Yep. We'd like to get, so remember last year how we did it in multiple spaces just so that people had some distance and they were safer, both the providers and the students? We're going to do
Yeah.
the idea is to do the same thing when you come back, at least again for a week or two. And then if everything continues to go down and die down, then the idea is that you will all be back on campus for morning and afternoon sessions. But when we first tried to do this, as you got back from winter break, we tried it, and then because of the intensity of where things were, half your class was out of class, whether it was positive or contact tracing or travel problems or other excused absences. Half your class was out in 3 days. We
Yeah.
don't want that to happen. We want to be able to bring you back safely and continue to have classes, because at this point, it's been a month, right? Since classes started. We want to continue. We want
Great.
to be back here. Okay?
When we do come